Right. Good morning, everyone. My name is Trevor, or T-Bone. I'm one of the PGY3s. My procedure day talk is about cardioversion for stable AFib, a Flutter, subtitled The Juice and the Zeus, because we're going to talk about chemical and electrical cardioversion, obviously. Special thanks to Drs. Desai, D'Souza, Gennaro, Camacho, Fan, gave a lot of really great input on this talk. So, nope. Oh, wait.
Just click that.
Click. Boom.
And then you can do it after.
Love it. Love it. Okay. So these are the wonders to come. We're going to talk a little bit about why you'd want to cardiovert someone, some specific considerations prior to cardioversion. Then we'll get into both electrical and chemical cardioversion, the actual procedures themselves, and then we'll go through a couple of take-home points. So let's dive right in. So why cardiovert, other than the fact that it's fun? And I'm not arguing that rhythm control is inherently superior to rate control. I think they both have their place. We should be adept at doing either or. But cardioversion has been shown to improve quality of life in patients. They have improved functional capacity, better exercise tolerance. So those are important things, especially in talking to your patient about the potential for either rate or rhythm control strategy, is making sure that they're aware that most of the data shows that it's more quality of life improvement than anything else. Patient satisfaction is also increased when looking at rate versus rhythm control, especially in the ED setting. Interestingly, actually, one of the studies we're going to talk about, RAF2, they had about 500 patients who they couldn't enroll because they had such a strong preference for one or the other strategy. So it's definitely an important point and a recurring point throughout this talk is going to be basically shared decision-making with your patient about what strategy they prefer to undergo. Additional consideration is that patients who are going to be discharged, especially if they're, well, only if they're discharged in normal sinus rhythm, they actually don't need anticoagulation if their CHA2DS2-VASc is less than 2. So that is another consideration. You could potentially be discharging these patients without an increased risk of bleeding from being anticoagulated. Now, there's some theoretical potential benefits also to putting patients in normal sinus rhythm. One is that the theory goes that AFib begets AFib. There's structural remodeling in the atria that makes it more and more difficult to put someone back into sinus rhythm when they spend time in AFib. So potentially you could be reducing not only their recurrence, but also their overall lifetime burden of AFib. And as a corollary to that, also theoretically, is that you could potentially be reducing their all-cause mortality, because we know from population studies, patients who have AFib have an increased all-cause mortality rate, especially it's mostly secondary to stroke. This hasn't been shown to be the case in studies that have been done, so it is still a theoretical benefit, and definitely not proven, not borne out in the evidence, but makes a lot of sense. Plug for a really great app that I found while going through this, while making this talk, is ACEP actually has an EM point of care app that has a lot of different widgets on it, one of which is basically evidence-based guidelines to the management of AFib in the emergency department, all basically backed by our professional society. So it's a great tool, and I did reference it quite a bit in this talk, so something to take a look at. So patient selection. So like we talked about, we're going to go through what are the important factors you want to think about when deciding to even consider a cardioversion or rhythm control strategy. So off the bat, if a patient is unstable and you suspect that their instability is due to their rapid rate from AFib and not obviously another cause, instability being in most studies and in ACLS identified as either altered mental status, obviously frank pulmonary edema, or hypotension. Those patients, as per ACLS, should just get electrically cardioverted. Now, otherwise, a couple of considerations would be patients who are relatively healthy and young being less than 65, these patients typically will have the least risk of stroke after putting them back into normal sinus rhythm. And it seems to be that patients less than 65 also have increased likelihood of converting to normal sinus rhythm. So from a safety and from an efficacy standpoint, these would be some considerations. They're not at all, these aren't guidelines, but they're just something to think about. These are the patients that might benefit the most from being put into normal sinus rhythm. Likewise, CHA2DS2-VASc score less than 2. Again, not a hard and fast, you must only convert patients with a CHA2DS2-VASc less than 2. Obviously, if they're appropriately anticoagulated, that would be another consideration. Patients who have clear symptom onset less than 48 hours. This is important, especially if you're going to decide whether or not you're going to anticoagulate them before cardioversion. You want to make sure you have a reliable patient who's able to give you a very clear timeline of onset of their symptoms. Alternatively, if they are therapeutic on anticoagulation for at least 3 to 4 weeks, the onset may not be as important. A lot of the guidelines say that if a patient has been symptomatic anywhere within the last 7 days and they're therapeutic on anticoagulation, they are probably safe to cardivert. Here, underlying etiology, I have it with a question mark because ultimately rhythm control strategy is probably not going to be appropriate or beneficial to the patient if their AFib with RVR is due to an underlying cause. So things like obviously PE, sepsis, hyperthyroidism, coronary artery disease, acute ischemia, these are going to be better treated. The AFib with RVR is going to be better treated by obviously treating the underlying etiology. So lots of the studies also exclude patients who are coming to the ED for anything other than symptoms related to their rate and their AFib. So those are considerations that we got to think about. So are there many ways to skin a cat? Any taxidermist worth his salt will tell you yes, of course. You know, talking about rhythm versus, talking about electrical versus chemical cardioversion, there's definitely things that would sway you possibly to one versus the other. Electrical cardioversion is more effective. Most studies show that it works 90% of the time to put the patient back into normal sinus rhythm. The downside of electrical cardioversion is it is painful and it requires procedural sedation. So all of the risks inherent with procedural sedation and the one-to-one nursing ratio involved, as well as you at the bedside, might preclude your use of electrical cardioversion, especially if you're in a small shop, a single coverage kind of ED. Those would be, or if your patient is just not a great candidate for procedural sedation. These would all be considerations. Chemical cardioversion has the benefit of not requiring procedural sedation. Many of the agents are actually quite safe and not necessarily requiring a one-to-one nursing ratio. The downside of chemical cardioversion is that lots of these agents do have some nasty side effects, and they're typically only about anywhere from 50 to 70% effective in a lot of the literature. We're going to talk about only 2 agents when we get to the chemical cardioversion part of the talk, and we'll go over why I chose those at that time. So this is your setup for electrical cardioversion, and you'll notice that it's basically the setup for any good procedural sedation. So you have your patient who looks suspiciously like the man on all the bathroom signs, and he's on the monitor. We have our end-tidal CO2 monitoring as our more sensitive marker of hypoventilation rather than pulse oximetry, but obviously they're on both. We have all of our airway adjuncts, not just our BVM hooked up to oxygen and our laryngoscope blades, but also all of our adjuncts, bougie, video, LMA, our supraglottic airway devices, everything you're going to need for both rescue maneuvers, but also for a potentially difficult airway. We sometimes forget how important that is to have all of our airway tools at our disposal when doing procedural sedation, but you want to plan for the worst. Patient is on, obviously hooked up to the defibrillator, pads are on the chest. Now you'll see that our bathroom sign guy, he has anterolateral pad placement. We'll talk about which one, if any, is preferred a little bit later on. We have good IV access, and then we have our sedative agents all at the ready. Talking a little bit about anticoagulation. So in low-risk patients, there's actually quite a lot of, there's a big difference when you look at different guidelines. And I think a lot of it is a result of there being really pretty low quality evidence suggesting one or the other. But so on the left is the ACA, the American Heart Association and the American Cardiology, American ACC, these are the guidelines that they have stated. So patients, symptom onset clearly less than 48 hours, and a CHA2DS2-VASc of 0 in men or 1 in women, you can either consider or forego anticoagulation in those patients, both prior to and then after cardioversion. Now you'll see it's a 2B recommendation, which means that it's weak, and it's based on BNR is moderate quality, non-randomized study data. So clearly not a strong endorsement, and obviously they're leaving the decision up to the provider for these low-risk patients. Now, the Canadian Cardiology Society, these are their 2020 guidelines, and they have a far more, their risk tolerance is much less in this recommendation. And you see that basically what they recommend is that anyone getting cardioverted go home on 4 weeks of post-cardioversion anticoagulation. And then basically after that point, long-term anticoagulation is based on the CHA2DS2-VASc score. The reason they make this recommendation is because many studies that have looked at the risk of post-stroke, post-cardioversion, there is an increased risk in pretty much any patient, including patients with a low CHA2DS2-VASc score. It's small, but it exists. So that's why their recommendation is to anticoagulate all patients who are getting cardioverted. Now, when you take a look at their data, they also base this. It's a low quality evidence and a weak recommendation. So again, not supported by any strong conclusive evidence that this is beneficial to your patients. So it's really something that, again, is mostly up to the physician's discretion. So talking about procedural sedation for cardioversion, this is a great resource that kind of makes the rounds periodically. It's basically a procedural sedation analgesia checklist. It's a Ruben Strayer. I was going to print some out and then hand them out, but then I didn't. It's a really great resource. You can look it up online, and it basically, it's not just good for kind of at the bedside when you're doing procedural sedation, but it's a great tool to kind of look over all of the things you want to think about pre-procedure assessment-wise, and then looking at the doses of your agents, special cases where you may or may not want to use those agents, and et cetera. So great resource I wanted to highlight. In talking about which agent is superior, there's no good data. There's a 2015 Cochrane review that looked at this, and they basically said insufficient evidence to suggest one agent over another at this time. That being said, I think that some agents just are going to be better in terms of the timeline of their sedative onset and offset. So things like propofol, etomidate are probably going to be your go-tos. Some meta-analysis and reviews have said that benzos have too long. They basically post-procedure, the recovery period is longer than other agents like etomidate and propofol, and there's some post-procedural confusion which can complicate your recovery course for these patients. Obviously, propofol and etomidate are not without their own issues. Propofol causing hypotension, bradycardia, and etomidate causing myoclonus. So most important part of the procedure, obviously, is the synchronization bit. So pressing sync on the defibrillator, and on this defibrillator, the sync button is a soft key down here. So when you push that button, what you should see is a down arrow that's marking the most the most positive or negative deflection on each beat. And what this is doing is it's ensuring that the defibrillator, when it delivers a shock, is going to deliver it. It actually shortens the shock to be less than 4 milliseconds and synchronizes it with the peak, basically with the QRS. Reason being to avoid basically shocking a patient during the vulnerable period of repolarization, which can basically start put the patient into either polymorphic VTAC or VFib, because it will land on, it could potentially land on causing like an R on T phenomenon. So that's why we synchronize. That's the most important thing. And actually in RAF2, the only patient with cardiac arrest post-cardioversion got shocked without synchronization. So it does happen. You got to be very careful. So how much? That's another question we want to ask. There's a really great trial, pretty recent, called the BEST AF trial. And they looked at basically a progressive dose escalation from 100 joules to 150 to 200 for cardioversion of AFib versus another treatment arm that just started at 200 joules. And what they found was that 200 joules as a first shock was effective more often than the dose escalation group. It looks like a lot of the increase in efficacy was actually seen when they did subgroup analysis. It was patients with a BMI greater than 25 who showed who actually had the statistical difference and the increased rate of cardioversion with 200 joules. But I think as a general rule, 200 joules is as safe as 100 joules, and it's likely to be more effective. So I think it's a fair recommendation to make. For a Flutter, it's a different pathophysiology, and 50 joules is the recommendation. Pad location doesn't seem to matter. And again, in RAF2, they basically had a nested study within the overall study that looked at pad placement, AP versus anterolateral, and they found no significant difference in cardioversion rates. So dealer's choice when it comes to pad location. Sort of the complications of electrical cardioversion, there are obviously some. Healthcare worker injury is one thing to be mindful of. Typically simple, like, burns and shocks would be the things that we would want to think about from a healthcare worker perspective. That's why we say clear. That's so there's that. In terms of patient complications, hypoventilation and apnea are risks involved with electrical cardioversion. Also, cutaneous burns would be another consideration. Cutaneous burns typically occur with inadequate adherence of the pads to the chest. You also want to be mindful not to put pads over any medicated patches or any creams, especially nitroglycerin, which can explode. So definitely need to wipe off all medications from the chest prior to pad placement, or choose a different pad location. Post-cardioversion arrhythmias are also something to think about. Sustained VTAC and VFib in most case series, sustained VTAC and VFib versus non-sustained VTAC seem to occur in patients with a history of VTAC and VFib. So obviously, if your patient is known to have a history of going into either VTAC or VFib, you'd want to pay very, very close attention to them once they're undergoing cardioversion. Bradycardia is another complication of electrical cardioversion. Patients who have a history of coronary artery disease or have ongoing coronary ischemia seem to be at the highest risk of developing bradycardia as a result of electrical cardioversion. So those are patients you want to be very careful with, and just keep in mind that they are at higher risk for this particular complication. So we're going to talk about chemical cardioversion now, and I just want to give a shout out to some of our faculty who basically did a really excellent review about exactly what we're going to talk about. So mad props to the funky bunch, good guys and gals. Yeah. Yep. Yeah. So we're going to talk about abutolide first, and the reason I want to talk about abutolide is it is backed by ACEP as an agent that is within our practice, within our purview to use. Many studies have demonstrated its safety and efficacy. So it's something that we should be comfortable with. It's a class 3 antiarrhythmic, which means it's a potassium channel blocker. The success rate is anywhere from 50 to 70%, depending on the study you're looking at. There is a risk of VTAC, and actually Abutolide has a black box warning for this reason. Now, in earlier studies that looked at a prior dosing strategy of Abutolide, the rate of VTAC was quite a bit higher, about 5%, which is why it has that black box warning. Using the dosing strategy we're going to talk about coming up has been shown to have a VTAC rate of about 0.6%, so pretty darn low. There are some considerations and some contraindications to using Abutolide, and they're right there for you. So QTc prolongation, a known ejection fraction less than 30%, or marked hypokalemia all should cause you to choose a different agent. So the how-to of Abutolide chemical cardioversion, pre-treatment with mag sulfate has been shown not only to potentiate the effectiveness of Abutolide, but also to prevent ventricular arrhythmias. And when looking at the dose that is effective for prevention of ventricular arrhythmias, it's high doses of mag sulfate that have been shown to do this. So pre-treating with 5 grams over an hour prior to infusion of Abutolide, and actually subsequently providing another 5 grams over the following 2 hours. So it's a total of 10 grams of mag sulfate. This dose was safe, and the rate of adverse reactions was pretty minimal. The things that you expect with mag infusion, so flushing, tingling, dizziness, were seen in about 14% of the patients, but that's all. And the trade-off is a lower rate of ventricular arrhythmias, so I think it's worth adopting. So Abutolide, you give 1 milligram over 10 minutes if your patient is over 60 kilograms. You can redose that in 10 minutes if you don't achieve chemical cardioversion. The thing about Abutolide, though, is that patients do need to be monitored on cardiac tele for 4 hours post Abutolide administration for QT prolongation. So it does inherently increase the patient's length of stay if your plan is to discharge from the emergency room. So the next agent we're going to talk about is Procainamide. I want to talk about Procainamide for a couple of reasons. One is that a lot of the recent studies out of Canada do show that it is both safe and effective, although it's not an agent we're very comfortable with for this indication. It's also not an agent that we typically use in the emergency room, as it does have a number of adverse reactions that are potential. But it has been shown to be highly safe and effective. We talked about the RAF2 trial. So just kind of the RAF2 trial itself was a study where they looked at basically 2 treatment arms for patients in AFIB with no other complicating factors. They looked at drug shock, which was basically a group where they administered Procainamide, and then if they didn't cardiovert with Procainamide, they went on to electrical cardioversion versus shock alone. And what they found was that in the drug shock group, 52% of those patients didn't need to go on to get electrically cardioverted. They were in normal sinus rhythm. So it's an interesting protocol that one could consider as basically chemical cardioversion first, either with Procainamide or maybe something like Abutolide seems to possibly potentiate the effect of electrical cardioversion if needed. RAF2 actually didn't show that. It was like 92% cardioversion in the shock-only group and 96% in the drug shock group. It didn't reach statistical significance, but it's an interesting protocol that may avoid the need for procedural sedation and subsequent electrical cardioversion. So Procainamide, it's a class 1A antiarrhythmic, which means it's a sodium channel blocker. It also has about a 52 to 55% success rate in RAF2. That's what they found. Patients obviously do need close cardiac monitoring. So this still requires basically one-to-one nursing when you're using it. The dose is up to 17 milligrams per kg, and you administer it at about 20 to 50 milligrams per minute. In RAF2, this was their protocol. They basically stopped if the patient either converted to normal sinus rhythm, experienced QT prolongation greater than 35% of the baseline, had QRS prolongation, or if they became bradycardic or hypotensive. Hypotension was by far the most common side effect of Procainamide infusion, And what they did was if a patient developed hypotension, they stopped the drip, provided a 250 cc bolus. If that resolved the hypotension, then they continued the drip, and this was found to be a safe practice. So that's really it. That's what I want to talk about. That's so take-home points are going to be patient selection is critical, shared decision making, making sure that patients are aware of the known and the evidence-based benefits of cardioversion to normal sinus rhythm versus the risks. Safety first in everything, obviously. Don't forget to sync and consider chemical cardioversion. It is safe and effective. We have a lot of evidence backing up the use of chemical cardioversion, and have fun. That's my dog. And these are my references. No questions.